Hi everyone, welcome to this the first webinar of this new year, the first lunch with RITA 2024. So I am Professor Deiva. I'm a pediatric neurologist. I'm from France, located in the snowy Paris today, and I'm also the coordinator of the National French Reference Center for Rare Autoimmune and Brain and Spinal Cord Diseases. So today we have two world-renowned pediatric neurologists and who are also experts on neuroimmune diseases in children. And they are going to talk about the topic that we have established, which is how do I treat childhood encephalitis? So we will start, we will end the discussion with Madame Elices Pascale, who's the president of the an association which is called ENMDAR, which is an association for patients and parents with children with NMDR encephalitis. So it's a great pleasure that I would like to introduce Professor Rostasy, who's the pediatric neurologist, the head of the department in Datteln, and who is also the president of the European Pediatric Neurology Society. So again, a big thank for him to be able to take time to talk about the topic. Kevin, the floor is yours. Thank you very much.
Yeah, thank you very much. I hope you can hear me all and that the presentation is uploaded. And I would like to talk the next 15 to 20 minutes about antibody-associated autoimmune encephalitis and particularly focus on a differential diagnosis and on the 3 or 4 common types of antibody-mediated autoimmune encephalitis. And the next slide, that's the introduction. Then we talk about autoimmune encephalitis and a brief summary at the end. As you know, in recent years, there have been quite a significant advances in the different fields of neuroimmunology. And I like to point always out that the clinical and radiological characterization of children with MS, part of many international collaboration, has really led to the description and to the precise diagnosis of MS in the majority of children. And we have 2 successful, or at least now 3 successful trials, the TerryKids paradigms, and also a third one that have shown that especially high efficacy drugs are very useful in these diseases. And very importantly, acroprin 4 and MOC antibody diseases are on have been described in more detail. There are new criteria, and the last point I would like to mention is that over the last 10 years, a series of autoantibodies, especially attacking neuronal and glial antigens, have been described and have led to a complete new realm of diseases. And just to give you a highlight, I mean, this is a slide by Frank Leipold. You see here many different autoantibodies, and the list is not complete. But in pediatrics, the main antibodies we have to talk about is either the NMDA receptor associated encephalitis, and I believe that that's a personal bias, but that MOC antibodies are leading also often, especially in the situation where you have a viral meningitis, that often MOC antibodies also do play a role. Several others, like glycine receptor antibodies, especially in cerebralitis, and I will talk a little bit about GFAP-associated brainstem encephalitis or cerebralitis, are important autoantibodies to have in mind. Now, before talking about the specific autoimmune encephalitis, I would like to point out that the differential diagnosis always should be kept in mind, even if you think that's the diagnosis of that and that antibody-mediated disease. But please keep in mind that especially acute necrotizing encephalopathy or HLA or macrophage activation syndromes and neuroborreliosis in our country and mitochondrial disorders, I will show you one example, are always important differential diagnosis. And at the beginning, it's sometimes very difficult to decide. And I'm sure Ming will later talk about also about the antibody-negative diseases. That's where other diseases always come into mind. Now, here, an interesting patient. It's a 9-year-old boy with increasing somnolence, weakness. He has a elevated CSF cell count and a high protein. And the initial EEG showed generalized slowing. So if you have the Gauss criteria in mind, when this child at presentation, it's a very quick presentation, fulfills also taking into account the pathological MRI. That could be, if you exclude viral and bacterial and other diseases, that could be the presentation of an autoimmune mediated process. But just to illustrate how difficult it is, you see here the MRI changes, which are very symmetrical. It's like somebody has drawn them with a lineal and a pencil. It's mild basal ganglia changes in the thalamic structures. So that was the initial diagnosis below. And yeah, ADEM, I wouldn't call it because of the missing white matter involvement, but acute necrotizing encephalitis or Lee syndrome or a pathogen-induced disease. And I was very surprised that actually turned out to be a pathogen-induced encephalitis and a tick-borne encephalitis. And going back into the literature and looking at children who end up in a rehabilitation center with tick-borne disease, they actually often have this type of pattern of MRI features with thalamic involvement and also putamen and striatal involvements. So this is, if you see a child day one, it's often very difficult to say what the final diagnosis will be. Another child we had encountered where we strongly thought that this might be an encephalitis and autoimmune mediated was a 4-year-old child of congenious parents. That's also already a red herring, presented with ataxia and altered consciousness and seizures, slightly elevated CF cell count, slightly elevated lactate, and generalized slowing, but did respond to immunoglobulins and steroids initially very nicely. This child is described in this paper below, mentioned in more detail, but just to show you the initial MRI with the changes in the hippocampus. Here on diffusion weighted images, the DVB signal is elevated with an ADC signal reduction, so indicating more cytotoxic injury. And with steroid treatments, the child improved rapidly and also the changes disappeared completely. So we had discharged that patient with a presumed diagnosis of limbic encephalitis with no antibodies found at the time. And then 10 months later, the patient came with another episode of severe ataxia, vomiting. And here you can see the massively swollen cerebellum leading to the death of the child. And in retrospect, a triaxon was performed on skin fibroblast and discovered a homogeneous near-splice variant in the NAXA gene. And there are reports of this group of diseases that these children often present with cerebellar involvement, leading to brainstem infarction and impairment and subsequent death in these children. That was for us a very dramatic case. I would have bet that the initial episode was autoimmune triggered, but in retrospect, the red signals, or the, how you say the red flags, were congenious parents and a slightly elevated lactate on the second time. Now, so this is, everybody has a list of differential diagnosis, and for example, for me, another disease subtype is HLA, or macrophage activation syndrome, which can have very variable clinical picture, and that's something because it's so steroid or it's improving on steroids, you have to always keep this diagnosis in mind. Now, coming to the antibody-mediated diseases, I start not with a neuronal antigen, but with a mock case. And this was, for me, the first case presenting in 2015 with all the features of a viral meningitis. And at the time, the obvious pathological thing on MRI, which was not appreciated at the time, is this ribbon-like cortical involvement on one side of the hemisphere without contrast medium enhancement, diffusion changes indicating vasogenic edema, because the ADC mapping is always normal. And this child initially had multiple focal seizures, a right hemiparesis, and still suffers from that, and CSF cell count elevated and these lesions. So at that time, the child was diagnosed with a viral meningitis, but had two further episodes in 2018 and 17. And on the second and third time, because it was part of our screen, mock antibodies were taken, and she has a persistent high mock antibody titer and has a recurrent MOCA disease with the phenotype meningoencephalitis. This is a second boy, also very typical, with seizures, somnolence, CSF elevated, EEG slow, MRI focal cortical lesions, particularly well seen on the FLAIR images. The nice thing is they very nicely respond to steroids, and the majority of these patients with mock encephalitis does not seem to have a relapsing disease, but official data are not out on this subtype of diseases. So nicely described in this paper by Andreas Wegner-Panzer, the clinic, the radiology. The second really common and subtype is obviously NMDA receptor encephalitis. And here in my fifth case, I show you the disease symptoms. Sorry, I have to sorry about that. These are the typical symptoms of a child with a fulminant encephalitis. She started with headaches, fever, and visual symptoms, and she was first admitted to the psychiatry unit because of the visual hallucinations. She then, on day 4, had orofacial dyskinesia and agitation, was transferred to our intensive care unit in Austria, and developed subsequently a movement disorder, very bizarre, with focal seizures and a severe autonomic dysfunction. And only 3 to 4 weeks into the disease, this case is a case from 2009, she was noted to have a teratoma, and by then first reports from Oxford and from Dalmo came along, showing that these patients with a teratoma do develop a disease called NMDA receptor encephalitis. And in my experience in the last years, there are some children who present with this type of sequence of symptoms, but I've seen now several children who only present with a movement disorder, who only have focal seizures, and the spectrum and the variability is quite interesting. This is a nice, very nice, still a very nice paper I like to reference because it describes very nicely the sequence of events. There's a nice acronym which is called ENMDAR research, and every letter stands for an important diagnostic feature of the disease. Now, one child in our cohort was actually a 17-year-old who presented to the ER with a syncope, and then she developed a bizarre combination of psychological symptoms which were very difficult to judge or to classify. And for me, very impressive was that she was switching in her clinical presentation basically from 1 minute to the other. 1 minute saying, look, I'm completely normal, I would like to go home. She would fulfill her task, but then in the next minute she would start with self-reassuring questions and saying that she has no sensation for time. And this is always a nice feature in children with NMDA receptor encephalitis, that the episodes do change, they are not consistent, and so on. Neurological examination was normal. She had a CFL count of 7, and her autoantibody screen initially was tested in serum and CSF. And the problem is always it takes 2 weeks in Germany. It's now getting faster, but you are in a situation to decide what treatment to choose. And because of a mildly elevated CSF cell count, we decided to treat her as an autoimmune encephalitis. And then the NMDA receptor antibodies came back and were highly elevated, in particularly in the CSF. And she was started or continued with IVIG and rituximab because of the severity of her symptoms. So this is a case to illustrate that she only had psychiatric features, and this has to be kept in mind. And ideally, you discuss a presentation like this with a psychiatrist in combination, and then you start the appropriate investigations and treatment. And another disease entity we have focused on in recent months is that we have had quite a few patients with a GFAP-associated immune encephalitis. And for me, that's the new kid on the block. And we have now collected from different partners in Europe, including Kumaran and Thais from Barcelona, up to 16 patients who often show brainstem involvement and myelin involvement. And this is a very characteristic patient of that group. It's a 7-year-old boy with ataxia, breathing problems, and an encephalopathy. And as you can see on the MRI, it's a longitudinal extensive transverse myelitis, and with brainstem involvement, especially the medulla, but also the pons and structures which are lying higher above. And it turns out that, or our impression is that especially when they harbor CSF antibodies, MRI features are much more present, and the cause of the disease is also much more virulent. You have to keep in mind, it seems to be a broad spectrum. Children who do not have CSF antibodies tend to be better, but we have a couple of children on our record that were also severely ill. And This is another interesting feature in this disease, that the majority of patients with a CSF antibodies, so they seem to have what you can see here around the aqueduct on the MRI, what we called a halo sign or Halo-Zeichen around the aqueduct. And it's often not immediately visible, but on a later MRI, in this case on day 11, you see this really bright signal around the aqueduct. Doesn't take up contrast medium enhancement. You can see it on the diffusion weighted image, but not on ADC mapping. And another feature often seen in the pons or basal ganglia, that you have this salt, what we call salt and pepper sign, with small punctate lesion here in a child on day 1 already, on the FLAIR image and the T2 signal. And this is a patient recently referred to us also with a small punctate lesion in the cerebellum, but also in the temporal lobes. So a broad spectrum, and it seems that CSF antibodies indicate a worse prognosis and more MRI changes. Last not least, a couple of words in regards to acute cereballitis, which often goes along with encephalopathy. And I call this disease then acute cereballitis plus. And here is a nice image series by Bolzhauser in Yildirim. And you can see that all these children were diagnosed after all with acute cereballitis, but the clinical presentation, especially on the MRI, can be quite variable, with bilateral, more white matter, or cortical involvement unilaterally. That seems to be more like a tumor, and so very variable presentation. And in a recent paper by Lisa Quark, also published in the European Journal, she showed a child, for example, with a glycine receptor antibody in serum and CSF. And you can see this here on the axial image with diffusion changes, and quite impressive on the transversal section of a unilateral antibody-mediated glycine receptor antibody cereballitis. So these are kind of my highlights when I think of autoantibodies. So NMDA, MOG, glycine receptor, GFAP. The spectrum is broad. The easiest, or not the easiest, but the most uniform clinical presentation is probably in MOG encephalitis with focal seizures, typical MRI, and MOG antibodies in serum. And Ming will talk about the criteria according to Gauss, which I believe probably also the criteria by Cellucci, which I'm not so familiar with, are helping in the timely diagnosis and therapy. So thank you very much for the first part.
Thank you very much, Kevin, for this nice presentation. Now it's also a great pleasure to introduce Professor Ming Lim from London. He's the HOD of the Children's Neuroscience Research Center in Evelina. So he's also a key and very important person for the neuroimmune community and for the many collaboration that we have done with the UK. So Ming Lim, the floor is yours.
Thank you very much. And I am sort of dovetailing into what Kevin has spoken about, and it's always difficult to talk about a condition as defined by not having anything to define it, type thing. So that's what antibody-negative autoimmune encephalitis is. So I'm going to try and allude to some of the clinical and radiological presentation of autoimmune antibody-negative AE. I prefer antibody-negative to what is becoming more trendy to be called seronegative, insofar that a lot but as Kevin had mentioned, it is measured predominantly, in the CSF. So it is really antibody negative, AE. The progress and in treatments and sort of management, but the real bottom line is that, and the take-home message should be that if you fall asleep in the next 20 minutes, you should treat it no differently to an antibody positive autoimmune encephalitis, except that because you don't have a biomarker, you've just got to be a little bit careful that you're not missing one of the differentials that Kevin had mentioned already, and also some of the what we call monosymptomatic presentations, where you have predominantly one symptom more than the other, particularly the psychiatric sort of symptoms. And of course, ultimately understanding neuro and immunobiology is going to help us progress that field further, because many patients are in antibody negative and we don't really know what is the perpetrator here, so to speak. Okay, so with that said, these are the clinical syndromes that children can present with when they have a whole host of autoimmunity. And this is pretty simply, how the brain functions, right? So you've got movement disorders, you've got limbic encephalitis, you have seizures because they point you to, something being wrong with the brain. And of course, you have the psychiatric and cognitive manifestations, and the motor dysfunction predominantly being of the demyelinating phenotype. And as Kevin has explained or discussed, the longer we live and the longer we learn about things, we recognize that one, the immune system is not going to be super selective. It's not going to say, I'm going to hit just the gray matter and not the white matter, and vice versa, as with MOG, antibodies that you hear about. So this is how a child may present, a 15-year-old with a generalized tonic-clonic seizure. Progressively gets worse until the child becomes encephalopathic and also may have psychiatric features. And if you took an MRI, you can see the sort of arrow pointing to the limbic system being inflamed, and this would be limbic encephalitis. And Kevin provided a list of antibodies that may give you limbic encephalitis, from LGI1, i.e. all the voltage, all the potassium channel associated sort of antigens, GABA, and many more. But in this child, this is antibody negative. So it's the syndrome that's important, limbic encephalitis, and you would go on to treat this with immunotherapy, which we'll come back to that little bit later. This is a second child, a girl who presents with a very disturbed mood, and then goes on to have auditory and visual hallucinations, and almost sort of Parkinsonian and bradykinetic in feature. And I hope to be able to show you there. So almost catatonic and stuck. I'm going to stop that because of and then what essentially happens is that all the investigations are negative. The conventional MRI is normal. You can see the PET scan demonstrating perhaps a reversal, i.e. the occipital high signal, whereas the frontal, low signal, all indicating that there is certainly brain dysfunction or perhaps, sort of inflammation. And she's also, antibody, sort of negative, and one of the many, that we have. And for a while now, we know that many children are antibody negative, and this is because of a whole host of things. The first, of course, is that we can only measure quite a few antibodies, and this is more of a historical tour through cohorts that we've had. So this is one that we published many years ago now, whereby the antibody negative rate, when at that time it was mainly ENMDAR and even just the voltage gated, not even the voltage associated antibodies being described, the percentage is about 60% being antibody negative. In a more contemporary cohort, whereby criteria are being used, and we'll come to that in a moment, it is probably about 40%. So we're detecting more, but also excluding more patients that are antibody negative because they don't fulfill the antibody criteria. You've heard MOG being, the new kid on the block, or actually the old kid on the block, because GFAP is the new kid on the block. And if you looked at Thais' very elegant paper, 7% of her cohort who were presenting with AE features were sort of MOG, positive, and we'll come back to that overall, figure. And this is our own sort of cohort of patients with MOG, and Kevin had mentioned that in his it's probably about that same percentage as well. So 10 to 14% have this cortical encephalitis phenotype. So if you're looking at it both ways. But the challenge really in autoimmune encephalitis is twofold, isn't it? One is the paradox here that despite there being inflammation as measured by antibodies, majority of the time the MRI is not positive, and if it's positive, it only shows a mechanism of inflammation. It doesn't tell you what the etiology is. And then the CSF, if you measure it at the wrong time, may not be reactive, or the intrathecal bands are only there if you measure them a lot later in week 2 or week 3. There are other markers that you may have read about, neopterins and CXCL13, but not generally available as widespread or clinically as possible, and also do not have this sort of immediate utility to be used in a wider circumstance, meaning that if you use it in patients presenting with acute encephalitis, it could be tricky. But if you knew the patient had AE already, or you knew that patient had a condition, Borrelia or something, then measuring CXCL13 may be particularly sort of useful. So this is the criteria that Kevin alluded to, the Childhood criteria. Slightly different to the Grouse criteria in that the Grouse criteria still tried to define it by sort of antibody, whereas a Childhood criteria takes an agnostic approach for you to be able to make the diagnosis of possible, i.e. to initiate treatment, because speed is important, and I'll allude to a little bit later, probable, and then definite. Definite is essentially when you find the antibody. And one key thing of the Childhood criteria is also acknowledging that children can have more polysymptomatic presentation, and if you have 2 of the features here, as you see, you should be initiating treatment or suspecting autoimmune encephalitis. This would be the differential, and some of the differential or some of the investigations would be to look for the etiology. But more and more so now, and this is what's not recommended here as much, is that we should be thinking about performing some of the surveillance bloods for starting patients on more effective treatment as they become more available, i.e. the biologics, so as such, even at that stage, because as you know, after your treatment with IVIG and PLEX, those results can be particularly falsely negative, or even falsely positive, one way or the other. And of course, if you identify specific antibodies, you will have the diagnosis of autoimmune encephalitis. And as I said, that was written at the time that the paper was published, but this is becoming sort of larger, and it's also an acknowledgement that serum can play a part in the diagnosis as well. And in the absence of antibodies, you do need some evidence of inflammation, either clinically as in or investigatively, and that's just why we focus on these sort of investigations here, and if they were present, then you have a probable diagnosis, and then obviously as Kevin mentioned, he published his first cohort of MOG many years after the patient presented, because you have a repository of samples, and then you can go back and look at it, and then you would invent the wheel and re-evaluate again. And the reason why this is important is because it's a systematic way. I'm not saying it's perfect, but it's a systematic way to collect patients of the same type. And I think I'd like to draw your attention to this cohort recently published in DevMed, a Chinese cohort of about 300 odd patients, so big size, and they looked at all patients suspected of autoimmune encephalitis and then carefully dissected them out to the definite antibody positive, and as you can see there, it's about sort of 30%, and of all the AEs, the probable antibody negative is 29 cases, so that's another sort of 30% of the 120 patients there that they have of autoimmune encephalitis fulfilling Childhood criteria. 20%, 25% are antibody negative. And you can see there that, you know, the sort of 12% or 10% of MOG, which is this little marker here, is consistent with what was published by, observed by Thais. So with time, this will come down, but it is still a sizable amount. About a quarter of patients are antibody, you know, negative. And the reason is simple in that, you know, our immune system is not only, you know, down to B cells, we've got other, you know, parts of the immune system, particularly sort of T cell auto reactivity, and also sometimes even the innate, you know, auto reactivity that we, you know, do not measure and cannot measure, you know, sort of as well. But I think the key bits and the convergence of literature and on every systematic review that has been done, and these are just some that I've highlighted, point to the fact that, you know, early and adequate immunotherapy improves, you know, outcome in neuroinflammation. Kevin alluded to all the clinical trials, you know, that were there already, particularly in MS, and of course, you know, we don't have that randomized control or that robust, you know, clinical data in some of these autoimmune encephalitides because of the rarity and also because of the nature of that, in that, you know, patients don't have a recurrent disease. So treating monophasic disease in the acute period is certainly more, you know, difficult than recurrent sort of, you know, disease as such. But the key themes is, you know, initiating first line treatment as rapidly as possible, followed by second line treatment. And we're not going to discuss maintenance treatment here today because majority of the autoimmune encephalitides are essentially conditions that are monophasic, predominantly, as I did say. And then, you know, if you're refractory to treatment, you know, what else do you go? And that's totally an area that's devoid of any evidence at all, other than, you know, rational based treatment rather than evidence, you know, based treatment. And some of the early literature had suggested that immunotherapy responsivity is seen both in AE positive and AE negative, you know, children as well. And you would have seen, you know, some of that, you know, sort of yourself. So this is shown you is the first, you know, cohort that we published 10 years ago. And the main difference is that if you were AE, you know, positive, people were more comfortable with treating at that stage. And you can also see there that, you know, if you were AE, you know, positive, you were more likely to be given, you know, second line or what at that time we were calling disease modifying drugs like rituximab and cyclophosphamide. Whereas if you were AE negative, you were not, you know, done that. But even at that level, you can see that in panel B and C, and this is measured by improvement. So if you've got a bigger improvement of MRS, as a lot of you will know, MRS is a sort of almost like a categorical scale, whereby 6 is death and 0 is 1 is, you know, good. So an improvement of 4 is quite significant, and you can see there that there's a trend that and we were very careful not to do too much stats here because, you know, the numbers are small, but hopefully the picture graph will show you that, you know, patients who did have immunotherapy had more chance of, you know, sort of improvement compared to not. And what we also recognize is that patients with antibody negative AE, probably as a result of not having as optimal treatment, actually do worse. They have a higher risk of, you know, post-encephalitic epilepsy, as you can see there, compared to ENMDAR. And also if you measure the full scale IQ and a few other sort of, you know, cognitive scales, they're significantly, you know, sort of lower. And again, because of the small numbers, we're careful not to do, you know, too much stats in this, you know, paper here. But of course, you know, one of the confounders of the cognitive outcome could well be the epilepsy itself, and there's no way to disentangle, you know, the two. But nonetheless, you know, they do worse. So put together, you know, should we be treating, you know, these patients more, you know, aggressively, you know, in the first place? We need to know the natural history, of course, and I've already, you know, mentioned that. And this is the graph that Kevin had shown you, coming from a different, you know, paper from the Dalmau group in terms of the progression and the slower recovery in NMDR encephalitis. So you've got to be cognizant, you know, of that, and the time that you investigate as well is also important. But the evolution is also important of, let's say, epilepsy. So this is a limbic encephalitis cohort. You can see that, you know, virtually every patient will have an improvement following immune treatment, but gradually over the course of 6 months, the seizures recur again. The seizures recurring again is not due to an activation of inflammation. It is due to the epileptogenic process taking that long. So if we were to measure the outcome of epilepsy, we would not intervene at the time that the epilepsy recurs, because that's done and dusted. We might consider an intervention earlier to prevent epilepsy, downstream. So that's knowing the window. This is a typical a paper that I generally show to highlight that our comfort levels change, with time. From This is paper from the 80s, as you can see there. Daryl DeVivo, a lot of you will know, quite famous for other things now, but to demonstrate the steroid effect in encephalomyelitis, they had to hold treatment for 2 to 4 weeks before introducing sort of steroids. And I'm glad that none of us will use that as sort of comfort level now, which makes it more difficult to do control study. But this is a meta-analysis that we did on about 1,500 patients with NDR cases. And I just wanted to show two things. One is that despite giving more and more second-line treatments and less patients having no immunotherapy, the time to initiation was not different between the two epochs. And the two epoch was picked because of titular paper we see as the paper of enlightenment that should have taught us how to practice in measuring NMDR encephalitis. And a lot of the confounders in the poor response could be related to just no time to initiation of treatment. And in this paper, it was measured as less than 30 days of onset of symptoms, not onset to hospital. So it's just a sort of salient reminder to us that we can get very good at doing things, but we still need to do the simple things well, which is to start treatment. Understanding the biology is important. You would know about the antibodies being sort of binding to receptors and inactivating the receptor, and your dysfunction, be it cognitive, be it a whole host of other things, could be due to this rather than a inflammatory neurodegenerative sort of process. And treating this two could be slightly different. We don't have time to dwell much more into this. But the final bit of understanding the therapeutic window is really how quickly your treatment works, right? So if you look at IVIG, steroids, and plasma exchange, we institute that as first line because we know they work as quickly sort of as possible. We know that if you wanted to start Ritux, the fastest it would work is probably 7 to 10 days as a B cell sort of depleter, so you would not see that effect until then. So knowing that is important. And I just wanted to spend 2 or 3 minutes talking about escalating to second line treatment. And there is of course a wider group out there now who is thinking whether the second line should be the first line, but that will leave perhaps for the discussion. And for many years now, and this is work done from Russell Dale, that rituximab, particularly used second line early, makes a difference to outcome as measured by MRS, as evaluated by the person giving it. So it's not the perfect study either, but you can see NMDR or MAS and MOSD, and neuropsychiatric sort of lupus. But Kumaran reminded me that in their French cohort, that sometimes more is not always better, but also how you measure it. So as measured by the MRS in the French cohort, whereby over 80% of patients were given either rituximab or cyclophosphamide, the MRS outcome was not different. But we now recognize that the cognitive outcome, at least in my observation, is certainly better, and that's a paper waiting to be done or to come out as such. And this is reflected in the nice Korean paper many years ago now, whereby patients both with antibody positive and antibody negative acute limbic encephalitis were evaluated, and if patients were still symptomatic, they responded to treatment. How do you define symptomatic? It is quite sort of subjective, of course, but at least from a personal level, if I were to have a patient with autoimmune, encephalitis, be it antibody positive or antibody negative, if they're not, had an MRS improvement of more than 2 points within, 4 weeks, I would consider that, and that is actually in the treatment recommendations for NMDR. If they've not achieved that, it would be considered inadequate sort of improvement, and hence you would escalate, as quickly, as possible. There's also the notion that some of the antibody negative patients may require a little bit longer, sort of treatment. So some may give 2 doses or 1 redose of rituximab, but that is not entirely evidence, based. So I'm going to come back to the, what do we do, after second line, sort of fails. And whilst this is the most sort of challenging, aspect of what we and Kumaran and Kevin sort of have to experience, because we get asked of this all the time. Just a reminder that the proportion of these is not, significantly high, and you're left with, the widening armory that you have essentially of biologics. And I'm not wanting to discuss that today, probably because of time, and probably because it sort of requires a much more data. But you can see that if Ritux does fail, IL-6 blockade, and moving up the chain of targeting the cells towards the plasma cell would be logical, but we still require sort of the evidence. You can look for more sort of what we call smaller molecule, sort of targets that have been looked at as well. And this is a whole, host of them, and some at best, I think, observational and anecdotal data of efficacy in autoimmune sort of encephalitis, just purely because the numbers being particularly small. And this is something that Kumaran introduced us to some years ago now, thinking about, the blood-brain barrier, meaning that if you identify, significant inflammation, then using an oncological approach for these patients, may be additionally sort of helpful. And knowing the biology. So if you look at the CSF levels compared to the serum levels, and I've drawn the 1 in sort of 300 sort of level there, in the sense that if you've got more than that level in the CSF, it suggests intrathecal synthesis, and perhaps those are the antibodies or antibody-mediated disease that require a more central strategy as opposed to a peripheral strategy. But we always come back to there's no free lunch. Even a single cycle of rituximab can induce long-lasting immunological changes in children, particularly in young children, or the more sort of intense sort of regime. And the longer-term side effects are poorly sort of documented, and we really need to start thinking about collecting registries for these patients. Don't forget that the whole patient is a whole, so symptomatic treatment is as important. So the use of antipsychotics, the use of anti-agitation medicines, and then sort of the dyskinesia and stereotypy. This might be specific to an NMDR, or the recommendations was in an NMDR sort of centered paper, but it would apply to any other condition as well. And I just wanted to finish here, not because Pascale is on the call, but because I always do that. Managing the patients really is the whole child, not just sort of immunotherapy, from sort of vocational achievements through to symptom management, through to social independence, and then the family support. And this was quite a nice paper done by the NCEF UK, now NCEF International group, demonstrating the ongoing significant problems of patients following both other encephalitides, but also NMDR encephalitis, again highlighting that the antibody negative group perhaps had a bigger symptom cluster, probably from biological reasons, but there may be other sort of explanations as well. So I'm going to finish there, and thanking, as Kumaran says, our ERN sort of RITA network that has been really instrumental in getting all of us together. Quite so many years ago now. Thank you.
Thank you very much, Ming, for this nice presentation. Now I will let Madame Pascale Elices to talk about her association and her views about the ENMDR encephalitis.
Yeah, so hello all, thanks for inviting me into this webinar. So I'm Pascale Elices, founder of the ENMDR Association in France. So I created it's a very young association created in May 2022. My daughter, my 6-year-old daughter has been dealing with encephalitis since 3.5 years and is followed by Professor Deiva in France. So, of course, as like many associations, the goal was to gather people and to allow them to share their experience on encephalitis and to help in a very humble way medical research. And for this webinar, I gathered some feedbacks from families and their daily difficulties. So first of all, the main difficulty, of course, is at the beginning of the disease, which is very sudden and violent, and you don't even recognize your child, who is another person. It seems like possessed by something really hard and strange. So you have to accept this and deal with this as you don't understand anything. Once you understand that it's going to be a very long disease, you have to accept that it's going to be a marathon, and it brings all the family down for years. So it's another difficulty to accept in the disease. What's difficult too, it seems like an in-between disease. So it's not like a cancer or something that you can get rid of very easily. You feel disabled, but not too disabled. And then after a while, some of the children can go back to school, but it's still difficult because you're improving, but not that much. So some parents feel very helpless and don't really know how to work with the medical and schooling stuff. So you go forward step by step, but it's very small steps, and you have to be very patient because it brings all the family, and everything is triggered by this marathon. Then many families told me that people would ask if their child was autistic, because some symptoms seems to be like autism. So they have to explain. It's another difficulty. No, it's not autism, but indeed it looks like autism. And then after a while, you tell yourself, is it really gonna improve? Because you know that autism, it's a long-term disease. So people feel stressed because comparison to autism can make you feel really depressed. I was told that even for teenagers, it's really difficult too, because at a certain age, you have started to build a social life. And when you stay like 4 months or 1 year, 2 years in hospital, you feel completely out of everything, and going back to life and to take over your work, your friends, you do feel very alone, and something really, really hard happened to you, and you don't really know how to deal with it, and if it will happen again. So it's like another puzzle of your life that you have to build, and you weren't prepared for this, of course. And what's difficult too is to plan a future. So both for teenagers and for families with young children, how is going to be the future? Because you know your child is improving, and as you said, it's a very long process. But difficulty is to plan school, even vacation, a normal life. Will it be normal in 6 months, in 1 year, in 5 years, in 10 years? Will he be able to work? Will she be able to have to marry, and so on? So all of these daily questions are difficult to handle for families too. And there is a group in France which was created 10 years ago on Facebook, and people share a lot of things. And it's difficult because they all compare disease treatments, and I see a lot of rituximab, methotrexate, and so on. So whatever, why did you get to have methotrexate and I didn't? Oh, you have rituximab and I don't. My neurologist, sorry, don't want to give it to my daughter, and so on. And you feel so helpless that you want the same treatment as the other person, and it's difficult to accept again that it's going to be a case-by-case treatment, and for you it can take 2 years, and for your neighbor he can be sick for 6 months only. So that's one of the main things to know as well.
Thank you very much, Pascale. Sorry, it's a great thing that you talked to us, and thank you very much for this talk. And now we have some minutes for questions, and I have seen one question too from for Kevin. Kevin, I don't know whether he's still on the call. It is about the GFAP encephalitis. The question is, could you share with us what was the treatment for the child with the GFAP encephalitis, and how did he respond?
The one I showed initially with a severe LETM, he responded very poorly to all the medications used. I mean, he's quadriplegic with a severe reduced size of the myelin, and he was treated in several different hospitals with basically all medications you can imagine. In the 16 patients we do follow, or we have now medical records, there doesn't seem to be a good theme in what would be the best treatment. And it seems that because treatment was often late started, this seems to be a defining factor, that the kids who were started earlier did overall much better than the ones who were started late.
Okay. There are two questions for Ming. What would be your red flags to reconsider the diagnosis of autoimmune encephalitis?
I think for me, I mentioned two red flags. One is that you partially fulfill the sort of criteria of Chillucci, so you don't have very clear-cut, sort of brain inflammation, or you don't have a CSF pleocytosis. And the second is that you have a predominantly sort of monosymptomatic, i.e. Psychiatric, sort of presentation. You should be thinking about, and another, cause for it. And obviously the rest are pretty much all the red flags for neuroinflammation, like, consanguineous, family history, atypical sort of presentation. And actually, as we've alluded to, resistance to treatment should always make us think about or refractoriness to treatment should always make us rethink, the diagnosis. And the key diagnosis that we can make a difference, as you know, is one, the mitochondrials, where we would actually stop, the immune treatments, or, the HLH, where if it's genetically predetermined, then you would have, different therapies sometimes, even, bone marrow, etc., type treatment. So yeah, so I don't think any more than you wouldn't know already, other than it doesn't feel right.
One question to Ming and also to Kevin. It's about what Pascale said. So as she mentioned that some treatment availabilities and the fact that some people would get some treatment and others not. What do you think? How can we respond to that specific comment or question of
harmonizing treatment?
Yeah, good.
Yeah, difficult question, and it depends on the preferences. But I think we have in this one paper by Nosardini, clearly you start with steroids and immunoglobulin, and if response is poor, you tend to be more rapid in introducing rituximab. Having discussed also a couple of cases with Dalmau recently, my suggestion would be that we should retreat or more often patients also with cyclophosphamide 1 to 6 doses who do not respond, because all the other modern drugs like botelimumab or interleukin-6 blockers, yeah, I personally feel that this old medications should not be forgotten.
Cool. I think with Ming, we have the Nosardini group, and with all of us has established a kind of not protocol but recommendations of treating these patients. And another question that Pascale asked is about the long-term progress of these diseases. Do we have any idea of this progression in the clinical aspect of this autoimmune encephalitis?
Yes, Ming?
No, I think it was a question for Pascale, but I think it's for us really key and important for us to publish long-term outcomes in this patient. And Kumaran published it recently with the French experience on the long-term outcome of ENMDAR encephalitis. So we used to think, or not we used to think, but it's always been reported in the literature that patients do particularly well. But we know that as they showed, 40 to 50% have some ongoing cognitive and behavioral problems, and this would not be any different in a whole host of other conditions. And that is really the outcome measure that we should measure treatment against, not a total improvement in MRS.
Yeah, but we have, or my colleague from Berlin has published a paper on NMDA receptor encephalitis showing that the brain volume changes are not expected for the age-appropriate brain growth in children with NMDA receptor encephalitis, and we have shown this on our poster on the EPNS that even for MOG, the expected brain growth over time is far from normal. It's not dramatic, but it's less than 4 to 6% compared to the age control group.
Yeah, great. I don't see any other questions on the chat box, and I think we are running out of a bit of time. So I would like really to thank again all of you, and I think it was a nice lunch with Rita, and again happy New Year again for this start of the year. And I will give back to Colleen to stop the transmission. Thank you very much, everyone. Thank you very much to the audience.
Nice seeing you. Bye bye.
Thank you.
Bye bye.
Thank you. Bye.